Hello and welcome. Today we will be talking about benzodiazepine like xanax and klonopin and valium and how we go about trying to taper a patient off benzodiazepines. Benzodiazepines are not considered first-line therapy for many anxiety disorders, and there is a lack of evidence showing that it can help obsessive compulsive disorder and PTSD. I'll share something with you, something anecdotal. When I first started getting help from a psychiatrist, I was prescribed a benzodiazepine. I was prescribed Xanax, and when that didn't work, I was prescribed Valium. And these didn't work because my anxiety source was my obsessive compulsive disorder. So the benzodiazepines did not work for me, and I actually got side effects from it, like slurred speech and drowsiness. But that's neither here or there. Today, we'll talk about tapering a benzodiazepine. And this is significant because continuing a benzodiazepine beyond 2 weeks may result in loss of effectiveness, development of tolerance or dependence, potential for withdrawal symptoms, and interference with the effectiveness of concurrent anti-anxiety medications like, say, antidepressants. At the hospital, we use benzodiazepines chronically to help manage aggression, and sometimes we may misuse them a little bit and use it for anxiety as well. But we try to minimize our use of benzodiazepines as much as possible, especially when they're discharged from the hospital. You don't want benzodiazepines out in the community. So when they're discharged, we have to taper them off the benzodiazepines, sometimes quicker than we'd like. And that's because general guidelines recommend not to exceed a 5 to 10% reduction of current dose of benzodiazepine every 2 to 4 weeks, which could take months. That's a 5 to 10% weekly reduction. Goal for patient is to have a more rapid and safe taper of benzodiazepines. This is a patient we looked at. He had to be discharged to the community, and his outpatient psychiatrist didn't want him on benzodiazepines. So there are two strategies we looked at for tapers of benzodiazepines in the literature. There's the direct taper, which I found in a couple articles, and the substitution taper, which I've seen in a couple guidelines. So this patient was on clozapine, and this study right here, he was on clozapine 1 milligram BID. So we looked at a couple studies to see how we should go about tapering this patient off the benzo. So this one study, they decreased the dosage of clonazepam by 0.5 milligram per 2-week period until 1 milligram per day was reached, followed by a decrease of 0.25 milligram per week. And then another study used a strategy of 25% daily reduction in dosage of benzodiazepine weekly over the course of 4 to 6 weeks, while adjunctively using medications to control withdrawal symptoms. So those are pretty quick tapers. Of course, if we're doing quick tapers like we wanted to do with our patients, they're at higher risk of withdrawal symptoms, so we have to be mindful of that and possibly start them on adjunctive medication to treat those withdrawal symptoms, which can be deadly. Benzodiazepine withdrawal symptoms can be deadly, so it's a serious procedure we have to do in tapering a patient off of benzodiazepine. The next taper strategy is a substitution taper. These tapers recommend using an equivalent dose of diazepine to taper because it comes in more manageable doses and has a longer half-life. The half-life of diazepam is greater than 100 hours. So if we switch someone to diazepine from a benzo with a shorter half-life, they're less likely to have abrupt withdrawal symptoms, and they'll have a slower decrease in the concentration of benzodiazepine. So we looked at a patient who is on clonazepam, and conversion equivalencies from a few studies estimate 0.5 milligrams of clonazepam to be equivalent to 5 to 10 milligrams of diazepine. And that's a big difference in the dosage between clonazepam and benzodiazepine. It's almost 2 times the difference, say 0.5 to 5 or 0.5 to 10, depending on which study we're looking at. It could be different on how we manage the patient when we cross taper with diazepine. So, for the sake of this patient, he was on 1 milligram BID of clonazepam, and that would be 20 milligrams BID of diazepam. All these benzodiazepines are dosed 3 or 4 times daily, even with the longer half-life. One health network made recommendations, guideline recommendations for benzodiazepine tapers, and this is the procedure they went. Use equivalent dose of diazepine for 1 to 2 weeks. Switch to diazepam 1 dose at a time over a few days to determine tolerance and to adjust so the patient can adjust to different profiles of action and make sure they're safe when switching. After 1 to 2 weeks, decrease the dose of diazepam to once daily. Cut the diazepam dose to a quarter of the initial dose once daily for 1 to 2 weeks. And then finally, discontinue the diazepam. This is a pretty abrupt taper for a benzodiazepine, but this health network has obviously seen good results with it. So for adjunctive therapy to manage with withdrawal symptoms, benzodiazepines can cause seizures. So when someone's withdrawn from it, benzodiazepines actually help treat seizure disorders. So when someone's withdrawn, it can precipitate it. So we want to add an anticonvulsant at the start of therapy and continue for 2 to 3 months after discontinuing the benzodiazepine. And we can use carbamazepine or valproic acid to prevent seizures in those who are at high risk. And we can also use agents to help with symptoms of withdrawal, like Lyrica, imipramine, Vistaril, clonidine, SSRIs, or sleeping aids, such as melatonin or Benadryl. But these drugs, they have heterogenic results, meaning that some studies shown efficacy of these drugs and benefit while others have not. And each one of these drugs have a different indication. Like you'd see the Lyrica for somebody who has rebound anxiety. Imipramine can also help with rebound anxiety. Vistaril as well, it can help with sleep. Clonidine can also help with anxiety and also tremors. SSRIs, those will help with rebound anxiety and depression, and sleeping aids as well. So, Xanax and Valium aren't the only benzodiazepines. They have whole equivalency charts that approximates the dosage equivalent of each benzodiazepine with one another. And they also have the half-life, so if somebody's on Xanax, we'll definitely want to convert them to a drug such as diazepam so we can begin the taper without acute withdrawal symptoms. you can see that klonopin and xanax, they have equivalent dosing. 1 milligram of xanax is equivalent to 1 milligram of clonazepam, even though clonazepam does have that longer half-life. 1 milligram of xanax equals 2 milligrams of ativan, and we can see how these are equivalent. This table, they looked at 1 milligram klonopin, and they made it equivalent to 10 milligrams of valium. But we're going to look at the World Health Organization guidelines taper, and they looked at the time of dose of diazepam and what they recommend as far as a taper schedule for a patient who was on 1 milligram klonopin BID, and they made a taper schedule based on that was spread out a little bit more. So they said initially convert the patient to diazepam 4 times a day, 10 milligrams 4 times a day. Then there's the first reduction where we, after 1 or 2 weeks, we decrease 2 of the 10 milligram doses to 5 milligram doses to a total daily dose of 30 milligrams a day. And then there's a second reduction where we convert another 10 milligram dose to a 5 milligram dose, and we convert one of the 5 milligram doses to no dose. And that'll give us 20 milligrams a day of valium. And then we have a third reduction after 2 weeks, and then a fourth reduction after 2 weeks. The WHO guidelines, they say there should be at least 1 week between dose reductions. Again, the longer we spread it out, the less likely we're going to have acute withdrawal symptoms. Like they say, time between each reduction should be based on severity of withdrawals. The longer the interval between reductions, the more comfortable and safer of the withdrawal symptoms. Alright, so next we're going to talk about adjuvant therapy. Withdrawal can be severe, leading to death, and can include seizures, rebound anxiety, cognitive dysfunction, insomnia, nausea, tachycardia, paresthesia, which is tingling in the extremities and in the body, muscle pain, gastrointestinal symptoms like nausea and shaking. So this is something we have to manage, and these adverse withdrawal symptoms is why we have to go slow and have a slow approach to tapering somebody off benzodiazepines if they have been accustomed to taking a benzodiazepine for a long time. Many adjuvant drugs are implicated in facilitating withdrawal. However, again, most have heterogenic results, and no drugs are currently recommended or approved to facilitate withdrawal after long-term use of benzodiazepines. A couple studies looked at Lyrica. It has been shown to reduce symptoms of general anxiety and withdrawal symptoms during benzodiazepine withdrawal, but does not affect the discontinuation success rate, meaning that a patient, even if they were prescribed Lyrica, they still had the same amount of failure as somebody who wasn't prescribed Lyrica. Imipramine, which is a tricyclic antidepressant, there's a study of that has been shown to have high discontinuation rates of benzodiazepines. This study took a dose of imipramine 180 milligrams a day, and this showed a higher success rate for benzodiazepine discontinuation during a quick taper off, 4 to 6 week taper off benzodiazepine period, with a 25% reduction of daily benzodiazepine dose weekly. They also looked at the effects of buspirone or Buspar in this study, and buspirone had no effect on discontinuation success rates. It was the imipramine that had the most effect. And imipramine is an antidepressant, but The patients, however, in the imipramine group reported more severe withdrawal symptoms. So perhaps maybe a different antidepressant that has a similar mechanism of action but a less dirty molecule. Tricyclic antidepressants are most equivalent to the serotonergic and norepinephrine antidepressants, reuptake inhibitors, and those have less side effects than these tricyclic antidepressants, which could increase somebody's sedation or increase cholinergic side effects. So the SNRIs are less likely to do that, so I anticipate that they could perhaps help with a benzodiazepine taper. And then there's treatments for, again, like anticonvulsant treatment, like carbamazepine and valproate. There's sometimes autonomic instability like hypertension, so we could use something like a beta blocker to treat that, or clonidine, which could have a dual effect in helping with tremors or even anxiety or cognitive impairment. Clonidine can even help somebody who's having cognitive impairment. So basically, in summary, by decreasing the dose of benzodiazepine gradually and changing a short-acting benzodiazepine to a long-acting benzodiazepine, it will provide safe and effective taper while minimizing side effects. Just had to fix that. Sorry about that. And then again, we talked about adjunct medications. They can be provided to help control withdrawal symptoms. Unfortunately, some withdrawal symptoms can be protracted and last up to a year or longer, such as insomnia, cognitive impairment, even something like GI issues can last a really long time. But the benefit of it is after discontinuing benzodiazepine treatment, benzodiazepine-free patients report significantly lower levels of anxiety and depression than patients still taking benzodiazepines. So there is a light at the end of the tunnel. And this probably happens because somebody is building up tolerance to the benzodiazepine and it wasn't effective, at least when the patient first started, and tapering off it, somebody will have less of the side effects and the sedation of the benzodiazepines and potentially have a better outlook. So hopefully you learned something. Hopefully this is helpful. Let me know if there's any information I missed out or I can learn from or got incorrect. I appreciate your time and listening to this. These are my resources. I'll just run through them very slowly in case you wanted to research further or look at some of the articles I looked at. And thank you once again, and I hope you have a nice day.